Hi everyone, it's me Dr. Ilyas and welcome to Sullysrounds. In this video, I am going to discuss about hyponatremia. As you know, hyponatremia is the most common electrolyte abnormality that we come across in clinical practice. But still, we have a lot of confusion regarding its diagnosis and management. I will discuss this topic in two parts. First part is regarding basics and approach to hyponatremia, and next part will have management. So, coming to the topic proper. Hyponatremia is not about sodium, but it is a disorder of water handling. In every case of hyponatremia, the basic problem is retention of free water. In every case of true hyponatremia, it is associated with water retention. This is a very important concept regarding true hyponatremia. All this free water is retained in our body. There are only three scenarios where free water is retained. The first one is in a patient with a normal water intake but no urine output. Actually, this is due to renal failure. And second case is there is normal water intake but inadequate urine output. It is because of the action of antidiuretic hormone, that is ADH. So it is actually ADH excess state. So there is inadequate urine output even with this normal water intake. So the third scenario is compulsive water intake, especially in patient with schizophrenia, and there is maximum urine output but still it is inadequate for that water intake. So these are the three scenarios where free water is retained in our body. Coming to certain basics regarding hyponatremia. As you know, the solute ingested per day is actually equal to the solute excreted via urine. And urine can be diluted to a minimum of 50 millimole per liter and maximum of 1200 milliosmol per liter. The normal solute load of an average person is actually 10 milliosmol per kilogram per day. So in a 70 kg male, it is actually 70 times 10. That is 700 milliosmol per day. It is the solute load of that individual. As you know, the concentration is equal to solute divided by volume. So in terms of urine, that means the urine concentration is equal to the solute load divided by urine volume. The normal solute load is actually 10 milliosmol per kilogram per day. So in a 70 kg male, it is actually equal to 700 milliosmol per day. Solute load is equal to solute excreted. So the minimum amount of urine to excrete this solute load is actually equal to 700 divided by 1200. We already studied that the concentration is equal to solute load divided by volume. So the minimum amount of urine to excrete this solute load is actually equal to 700 divided by 1200, where 1200 is actually the maximal urinary concentration possible and 700 is actually the solute load. So the minimum amount of urine to excrete the solute load is actually equal to 583 ml. So it is the minimum urine volume to excrete this solute load. And the maximum amount of urine that can be formed by this solute load is equal to 700 divided by 50, where 50 is the minimum concentration of the urine. So it is actually is equal to 14 liter. So a person can make 0.5 liter to 14 liter urine per day depends on the need. If a 70 kg man with a solute load of 700 milliosmol per day ingests 15 liter of water, that means this person can only excrete 14 liter of urine. So there is a 1 liter that cannot be excreted, so the free water is retained in our body and it results in dilution and the fall of sodium. So to get into trouble, people need to drink more than 18 liter of water per day or more than 2 liter in an hour. Then only it will result in dilution and hyponatremia. So coming to some basics regarding ADH release. So there are two physiological stimuli for ADH release. One is increased serum osmolality. Second is decreased perfusion. So decreased perfusion can be due to volume depletion or due to hypotension. All other stimulus are actually non-physiological. So this non-physiological release of ADH will cause euvolemic hyponatremia. So there are physiologic stimulus and non-physiologic stimulus like drugs, pain, anxiety, nausea, CNS disorders, pulmonary disorders like that. So these all disorders are actually lead to euvolemic hyponatremia. This picture shows nephron. So we can see the osmolality of plasma is actually 285 to 295 milliosmol, and this is filtered by glomerular capillaries, and the filtrate have the same osmolality. And in PCT, that is proximal convoluted tubule, there is isoosmolar reabsorption occur, and so there is no change in the osmolality. But there is water absorption in the descending limb of loop of LA, and it is resulting high osmolarity at the tip of the loop of LA, that is 1200 milliosmol. So beyond this tip of loop of LA, the tract is actually impermeable to water. It can be made permeable only with the help of ADH. So ADH, if there is increase in the ADH level, it can increase aquaporin in this distal tubule, and it result in free water reabsorption. So as I already told, ADH release due to non-physiological stimulus lead to euvolemic hyponatremia. So this is one of the basics in hyponatremia. So coming to the topic proper, that is approach to a patient with hyponatremia. As you know, hyponatremia is defined as serum sodium less than 135 milliequivalent per liter, and it is significant when it is less than 130 milliequivalent. So there are three questions you should ask in a case of hyponatremia. The first question is whether this hyponatremia is true, and second question is there any rapid clue to the diagnosis of hyponatremia, and third thing is, and what is the volume status of the patient. So these three questions should be asked in every case of hyponatremia. So the first question, is it true or false? So what is meant by true hyponatremia? True hyponatremia means hyponatremia with low serum osmolality. The normal serum osmolality is 285 to 295 milliosmol. So if the hyponatremia associated with serum osmolality of less than 285 milliosmol, this is called true hyponatremia. And if the serum osmolality is normal or high and it is associated with hyponatremia, this is called false hyponatremia. So true means hyponatremia with the serum osmolality less than 285. This false hyponatremia is again divided into factitious hyponatremia and pseudohyponatremia. So what is meant by this factitious hyponatremia? When hyponatremia is associated with high serum osmolality, that means more than 295 milliosmol per liter, this is called factitious hyponatremia. Actually, it is due to increased concentration of osmotically active particle in serum, like glucose in the absence of insulin and mannitol administration. These are the commonest conditions that lead to this factitious hyponatremia, and others like the glycine administration during TURP surgery. So hyponatremia with the serum osmolality more than 295, it is called factitious hyponatremia. So always look for random blood sugar and also ask for the history of mannitol administration. There is a correction formula for hyponatremia in case of high blood sugar. For every 100 mg per deciliter above 100 mg, sodium decreased by 1.6. If a patient with a blood sugar 500 and sodium level 126, so we can correct this sodium by this equation. That means in case of a blood sugar value of 500, it means 400 is above the 100. So 4 times 1.6 is equal to 6.4. So the actual value of patient sodium is patient sodium value plus the 6.4. If this sodium value is 126, measured value is 126, the actual value is actually 132.4. This is the correction formula for sugar in case of hyponatremia. So coming to pseudohyponatremia. Actually, what is pseudohyponatremia? Pseudohyponatremia means hyponatremia with normal serum osmolality, that is 285 to 295 milliosmol. Actually, it is a lab error due to the way sodium is measured, and it is not seen with the modern techniques of sodium measurement, and it is seen with the indirect ion measurement that is used in past. So this is occur in patient with hyperlipidemia, multiple myeloma that lead to paraproteinemia, and patients with IVIG administration. So here the serum osmolality is 285 to 295. So this is the blood in a test tube. We can see the RBC in the bottom and the plasma water and proteins and lipids in upper part. So in a patient with hyperlipidemia or hyperproteinemia, what happened is this plasma water is decreased due to the increase in the concentration of proteins and lipid. So even though lab measures sodium in plasma volume, they report the value as sodium in plasma water. By means of this, the sodium measured will be less. So it results in hyponatremia. This is actually pseudohyponatremia. This pseudohyponatremia is not seen with the modern lab methods, that is direct ion detection. It is only seen with the olden techniques. In many hospitals, the lab facility for measuring serum osmolality is not available. What we can do is, we can actually measure random blood sugar, liver function test, lipid profile, and ask for IVIG or mannitol administration. If everything is normal, it is actually a case of true hyponatremia. That means hyponatremia with low serum osmolality. So coming to the second question, that is, look for the rapid clue to the diagnosis of hyponatremia. So what are these rapid clues? The one is random blood sugar, that is hyperglycemia. Second is thiazide use. And third thing is hyperkalemia. So hyponatremia with hyperkalemia, we should also always suspect this kidney failure and primary adrenal insufficiency. And this renal function test, that is serum creatinine, and history of very recent marathon. So after marathon or during marathon, people used to take more free water, and it results in retention of free water and hyponatremia, and patient presents with the acute hyponatremic symptoms. And always look for this urine osmolality. In all cases of hyponatremia, the urine osmolality is actually more than 100. If we see hyponatremia with the urine osmolality less than 100, there are only 3 conditions. So what are these 3 conditions where there is low urine osmolality associated with the hyponatremia? The first thing is T and TOS syndrome, and second is beer potomania, and third is psychogenic polydipsia. So these are the 3 conditions where hyponatremia is associated with the low urine osmolality. So if TO and TOS diet or beer drinker eating 100 millimole per day solute, usually the intake is 600 to 700 millimole. But in case of tea and toast diet or beer drinker, the actual solute load per day is 100 millimole per day. So the minimum urinary concentration is actually 50 millimole per liter, and maximum is 1200 millimole per liter. So the maximum urine output by this 100 millimole solute load per day is actually equal to 2 liter. That is 100 divided by 50. It is 2 liter. And if this person ingests more than 2 liter per day water, what happened is this excess free water is retained in his body, and it results in hyponatremia. This is how tea and toast diet or beer drinking habits lead to hyponatremia. The basic pathology is actually low solute intake. So there is not enough solute intake to make urine and excrete free water administration. This results in hyponatremia. If urine osmolality facility is not available, we can actually substitute this urine osmolality by specific gravity. So a urine specific gravity less than 1.010 means the urine is hypotonic. That means the urine osmolality is actually less than 100. So this table shows how patient get excess water. So it can be due to ingestion of large volume of water, especially in patient taking MDMA. It suppresses actually aversion to take large water intake is suppressed by this MDMA drugs. And second is in case of marathon, and third is beer potomania, and in psychiatric conditions like schizophrenia that result in primary polydipsia. So again, drugs like MDMA and marathon, beer potomania, and schizophrenia result in primary polydipsia. Second is in hospital settings, that is the infusion of large volume of 5% dextrose post-operatively, or during prostate surgery, the infusion of hypotonic lavage fluid, that is also result in this hyponatremia. So the hypotonic IV fluid in post-operative state or in patient with excess ADH, it result in hyponatremia by means of excess water. So second table shows the conditions where there is decreased excretion of water. So in earlier table we saw conditions associated with increased water intake. Here we see the condition with decreased excretion of water. There are two factors associated with decreased water excretion. The first thing is low volume of distal delivery of filtrate. That means in distal part of the tubule, if there is low volume of filtrate reach, it results in a decreased excretion of water and free water retention. Second is actually increased action of ADH. So the first thing is low distal filtrate and second is high ADH. So what are the conditions that is associated with low volume of distal delivery of filtrate? One is condition with low GFR, that is AKI or CKD, and second is increased reabsorption in proximal convoluted tubule, and it is actually caused by decreased effective arterial blood volume. So it is due to loss of sodium and chloride through sweat, so in patient with marathon run, or loss of sodium and chloride via GI tract, that is in case of diarrhea, and through kidney by means of diuretics, aldosterone deficiency, or salt wasting syndrome, that is renal or cerebral salt wasting, or conditions with low effective arterial blood volume like congestive heart failure, liver cirrhosis, or nephrotic syndrome. So in all these cases, the basic pathology is low effective arterial blood volume, and it can secondarily lead to ADH secretion and retention of this free water in our body, that is result in hyponatremia. So three mechanism, that is low GFR, second is low effective arterial blood volume, and third is solute loss through GI tract or sweat. Second is condition associated with high ADH. One is physiological stimulus, second is non-osmotic stimuli like pain, anxiety, nausea, drugs like MDMA, SSRI, anti-epileptics, vincristine, pulmonary disorders like pneumonia and tuberculosis, CNS disorders like encephalitis, meningitis, and release of ADH by malignant cell, especially in case of small cell carcinoma of lung, and severe glucocorticoid deficiency, severe hypothyroidism. So again, these are the important mechanism to develop hyponatremia. So already discussed the condition with the excess water intake and conditions with the decreased water excretion. These are the two main mechanisms of hyponatremia. And the third question is assessment of volume status. Based on the volume status, patient is divided into hypervolemic, euvolemic, and hypovolemic. Hypervolemia is very evident in physical examination. We can see peel edema, raised JVP, ascites, etc. And also severe hypovolemia is also evident with hypotension and orthostatic hypotension or tachycardia. But it is very difficult to differentiate the subtle hypovolemia from clinical euvolemia. So this is the important step in clinical examination. Second is hypovolemic hyponatremia. It is actually due to salt and water loss with excess free water intake. So after vomiting or diarrhea and sweating, and or in case of primary arterial insufficiency. These are the conditions that is associated with hypovolemic hyponatremia. It is very important to differentiate subtle hypovolemia from euvolemia because management of these conditions are entirely different. So for this, we can use urine sodium level. If urine sodium level is less than 20, it indicates hypovolemia. And if it is more than 30, that indicates SIADH, that means syndrome of inappropriate ADH secretion. In case of CR, that means excess ADH, there is increase in the effective arterial blood volume. So this results in decreased reabsorption of urea and uric acid from proximal convoluted tubule. So it results in decrease in the urea and uric acid in blood. So a uric acid value less than 4 in case of hyponatremia is associated with CR. And also if the value of urea less than 46 mg per deciliter, it also favoring the diagnosis of CR. So coming to the algorithm. So if you get hyponatremia, you have to check the serum osmolality. And if this serum osmolality is high, that means more than 295, that means it is a case of factitious hyponatremia. If it is normal, that is 285 to 295, that means it is a case of true hyponatremia. And if the serum osmolality is low, that is less than 285, it means it is pseudohyponatremia. So if we don't have facility for measuring serum osmolality, we can rule out the factitious hyponatremia and pseudohyponatremia by means of random blood sugar, liver function test, lipid profile, and also ask for the use of mannitol, IVIG or glycine. So in case of true hyponatremia, the next investigation is actually urine osmolality measurement to look whether the urine osmolality is less than 100 to 200 or more than 200 to 300. If we don't have the facility to measure this urine osmolality, we can actually use specific gravity value, whether it is less than 1.010 or more than 1.010. So if the urine osmolality is less than 100 or the specific gravity is less than 1.010, it means it is actually ADH independent. So the causes are already discussed, that is T&TO syndrome, Beer-Potomania, psychogenic polydipsia, and also in case of renal failure, it is also an ADH independent condition where there is excess water retention due to decrease in the GFR. If the urine osmolality is more than 200 to 300, it is actually means the hyponatremia is ADH dependent. So in case of ADH dependent hyponatremia, check volume status of the patient. So patient can be grouped into hypovolemic hyponatremia, euvolemic hyponatremia, and hypervolemic hyponatremia. The causes of hypovolemia are GI losses, renal losses, and the causes of hypervolemia are heart failure, liver failure, nephrotic syndrome. The cause of euvolemic hyponatremia are hypothyroidism, adrenal insufficiency, and SIADH. Actually, SIADH is diagnosis of exclusion. So this is the algorithm of hyponatremia. So always look serum osmolality to differentiate true hyponatremia from false hyponatremia, and second, to check urine osmolality to look for ADH dependency, and third is to look for this volume status of the patient. To differentiate this subtle hypovolemia from euvolemia, we can use this urine sodium measurement, serum uric acid measurement, and also serum urea level. So this is the simplest algorithm for hyponatremia in our hospital settings. In this video, I discussed about approach to hyponatremia and some basic aspects. The most confusing part of hyponatremia is the management of hyponatremia. There are many guidelines and all are different. And the management of hyponatremia will be discussed in next video. If this video is informative, please consider to subscribe the channel. So see you soon with the next video. Thank you for watching.